Thank you for listening to the FND Society podcast. I'm your host, Erica Cotton, coming to you from Chicago. I have an excellent team, including Michael Romeo, our sound and production engineer, coming to us from Australia, and our content curators, Ingrid Hurritsauer from the UK and Chrisma Pretorius from South Africa. We also thank Megan and Robert for all their administrative support. This episode is jointly hosted with the International League Against Epilepsy Sharpwaves podcast. My co-host is Dr. Ayushe Sharma, a postdoctoral fellow in the Blumenfeld Lab in Neurology at Yale School of Medicine. Our guests this episode are Dr. Barbara Dworetzky and Dr. Dara Albert. Dr. Barbara Dworetzky is the A.J. Trustey Endowed Chair in Neurology, Professor of Neurology at Harvard Medical School, Chief of the Division of Epilepsy and Clinical Neurophysiology at Brigham and Women's Hospital, and the President of the Functional Neurologic Disorders Society. Dr. Dara Albert is a pediatric neurologist and epileptologist. She is the medical director of the multi-disciplinary Functional Seizure Clinic in the Pediatric Epilepsy Center at Nationwide Children's Hospital and The Ohio State University. The goal of that clinic is to help patients and families understand their diagnosis and move to effective treatment and improving outcomes. She has a passion and scholarly interest in medical education and serves as the Associate Program Director of the Child Neurology Residency Program. We discuss population similarities and differences among adults and pediatric functional seizures, key outpatient differential diagnostic considerations, and some of the challenges for functional seizure management within the epilepsy department setting. I really enjoyed this recording and sharing the hosting role. Well, thank you so much, everyone, for joining me today to discuss our Functional Neurologic Disorders Society and International League Against Epilepsy Sharpwaves podcast joint recording. And getting started, Ayushe, why don't you kick us off with our first question?
Hi, so I would love to just kick it off with understanding the key differences between pediatric and adult functional seizures. Dara, just to start off, do you think you could take us through key differences that separate peds patients in terms of presentation and triggers?
Yeah, absolutely. So, first of all, functional seizures are quite common in young people. The most common kind of age group of presentation overlaps with adolescents. So we see a lot of teenagers who present with this diagnosis, of course, young adults as well, but a lot of teenagers who present with functional seizures. So it is quite common. The way that the seizures look themselves are pretty similar to how they're described in the adult literature as well. But, some of the challenges that our teenagers face and some of the risk factors can be quite different. So I would say in general, there is less, not none, but less association with trauma, sexual abuse, PTSD in kids and youth who present with functional seizures as compared to at least what I read in the literature for adult patients. And more often the risk factors are kind of multifactorial, just sort of difficulty of being a teenager, right? So we have family dynamics, we have school pressures, we have peer challenges and pressures, bullying, internal pressures, the perfectionistic type of personality, wanting to get straight A's or the best college, things like that can be pretty significant stressors on teenagers and can play a role in the biopsychosocial development of functional seizures. And there doesn't necessarily have to be that strong history of trauma. And then likewise, the treatment, and I'm sure we'll get into treatment a bit later, but when we are thinking about teenagers, school is a big place of where they spend a lot of their time. And so treatment has to include some recommendations for the school for how the schools can help support our kids through this diagnosis. So I'd say those are some of the big differences.
Great. Thank you so much. Barbara, do you think you could take us through that same kind of rehash with adult patients? And I'm especially interested in what percentage of your adult patients have actual history of documented trauma and how that influences your treatment approach.
Thank you, Ayushe. The trauma story for adults is pretty high, I would say, somewhere around, depending on what you read, 58% or more. Not everyone will actually tell you that, and I have learned not to ask directly about it. I actually learned an interesting statistic a couple of years ago from one of our psychologists that said something like 2/3 of patients experience trauma. So you can just assume trauma and kind of move forward with that. I would say now, with all the wars and all the distress people are going through, it's probably even higher. Much of the trauma does not have to be physical or sexual abuse, although that is obviously a bit more common in women. Men have that as well, and they may not talk about it. There may be even more shame than women have with that particular topic. But it can be any type of, could be job loss, personal loss. Doesn't have to be a traumatic, abuse history. Interestingly, childhood adversity, which I'm sure affects children, but it's very common in adults with PTSD, and neglect being even worse than the attention you get from being physically and sexually abused, unfortunately, at least as my non-psychiatric background lets me know. So I would say that I approach it fairly gently now because I'm not a psychiatrist, and unless you have time to really debrief patients, it's really something that can traumatize a patient with FND and they will never see you again. And so we really try to help them through it. And I don't ask directly about it at all. What I might say is, tell me what it was like growing up in your home when you were young. And that to me is, if they care to share it, then I may ask another question about it. But if they don't, I just leave it be. And I don't just say, oh, I read in your chart, blah, 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 because that also gets them not to trust clinicians. And as you probably already know, many patients with this disorder come to the medical system already being traumatized by us, which is just so horrible. And that's one of the reasons why Dara and Erica and I will work in this field, because to do some of the injustice and try to help patients with better outcomes. Was there anything else I was supposed to answer here? Dara did
No, that's great. Yeah, no, I appreciate it, especially because your response really encapsulated how you balance acknowledging trauma as a risk factor without further traumatizing the patients or making them feel dismissed or like it's all in their head, because that seemed to be a common element before we knew more about this.
One more thing, just to follow on what Dara said about school. So for adults, it's often work or, getting them back. And this comes up a lot. How do you try not to get them fired or, in trouble in some way? Because financial stressors are another huge burden for, job loss, for example, for patients with FND. And so having some kind of response plan, both to the emergency department, or to keep them at work, is also very helpful.
Yes, definitely. That was actually my next question, both for adults and peds patients. So maybe back to Dara, could you tell us how you manage a child who's been diagnosed with functional seizures and how you manage their school response plan? What for providers this should include and what it should specifically not include?
Absolutely. So I think the first step to treatment is really getting the diagnosis right, making sure that we are certain that the diagnosis is functional seizures, and that the family and the patient themselves agree with that it makes sense, that they understand their diagnosis. If I, as the neurologist, feel confident in the diagnosis and I tell a family this is what I think it is, and they say, absolutely not, you're wrong, I don't believe you, they're not likely to move forward with treatment, right? They're probably just going to go see another neurologist or continue to, get additional evaluation. So I see that as my sort of superpower in the situation of like making the right diagnosis and then communicating that in a way that the patient and family can understand it and move from like, this is really scary, I don't know what this is, to like, okay, now I know what this is. Now what do I do about it? If I can get them to that point, then I am very happy and I can say, great, that's the right question. So now let's talk about what we do about it. And of course, as a neurologist, I'm not the one who is treating the patient, but it is my role to help kind of ease that transition and help convince the patient and family of what the appropriate treatment is and how to seek that treatment. I'm very fortunate that I work in a multidisciplinary team, and so I have a psychologist who is there with me. I also have a physical therapist who is there with me, and we can provide the patient and family some treatment strategies right then and there at the initial visit, which is fantastic. But we sort of think about treatment in a few different stages. So immediate, like short-term, medium-term, and long-term goals for them. The immediate or the short-term goals are, as I already alluded to, accepting and understanding the diagnosis. This is really important. And then kind of starting to reduce the fear and panic around the diagnosis a little bit so we can stop coming to the emergency room, for example, stop seeking medical evaluations and additional opinions. That's sort of the short term. The medium term is getting the kiddo back to their life. So getting them back to school, getting them back to sports, to activities, to hanging with friends, whatever it is that they want to be doing. And then the long-term goal is really the hard work, working with typically a CBT psychotherapist and sometimes psychiatry as well, and sometimes other team members to learn ultimately how to control this in the long term. But in the short and intermediate term, getting that kiddo back to school is really important, an important piece of that. So to answer the second part of your question, like what do we tell the schools? It's really, really important that we give them some guidance. Most of the school staff have never heard of this. Many times we hear from schools, they think the kid is faking it. They're just trying to get out of class. Even worse, I see so many kids who have essentially been kicked out of school. They've been asked not to return. They've been switched to online schooling because of these events, because of safety and liability, concerns from the school. And so we need to reverse that course quickly. So all the kiddos that we see in clinic, I provide a written, documentation to the school that explains what this diagnosis is and how we can best support this child going back to school and getting back to their activities. I also have patients' parents sign a release of information giving me permission to talk with the schools. So if there's some hesitation, if there's some, barriers to success in the school, then I meet with the school directly. So I have met, probably at least once a month, I'm having a meeting with school administrators and school nurse and staff to help them kind of wrap their heads around what this is and how do we help best support this student and how do we not call EMS, not, call medical lockdowns in the school, not kick the child out of school, not call their parents to pick them up every time they have an event. So it really includes, education and providing a plan that makes sense and that helps them support the kiddo going back to school.
Thank you. Adolescence seems hard enough, and adding this diagnosis in seems especially challenging. How do you additionally empower these patients, these young patients, to talk about their diagnoses with their peers?
Yeah, that's a really great question. And you're right. A lot of times school is a major venue of events, like where events often are occurring for the kiddos. And I think part of it is that fear, that panic, like, oh my gosh, I'm going to have events in front of my peers and embarrass myself or hurt myself in the school building, et cetera. So, really, I think empowering the child themselves, the teenager, the adolescent, with education about what their diagnosis is, helping them understand what's going on, helping them to know that it's not their fault, that they're not doing it on purpose, that this is not something they're causing to happen, but that they can learn to have some agency and control over what's happening. I think that can be very empowering. And then, encouraging them however they want, if they want to discuss this with their friends or it's really up to them what they want to share with their peers. Certainly need to talk with the school staff so they know how to help them. But as far as talking to their friends and peers, that's really, we just empower them to share what they want to share.
Awesome. Barbara, I'd like to ask you some more questions about the flip side in adults. One thing that I was very shocked by when I first started doing my own FS research was how debilitating these seizures are, just as debilitating as epileptic seizures. Can you talk a little bit more about how you approach your initial conversations when diagnosing an adult patient and how you discuss how their day-to-day life will be impacted, especially when there's already a trauma history in place?
Thank you for that question. I approach patients, like I would approach any patient, with empathy, trying to listen to where they're coming from, including what their experience in the medical system has been, like what have other people told you, because I've had some patients just say, whatever you do, don't say these are psychogenic or I'm out of here. And so I think that's really helpful information to start out with if they've been. So I'll say, I'll be curious about that. Tell me more about that, because, if I can't do like a full differential and you're coming from my expert opinion, I want to know a little bit more about it. So I approach it with, curiosity and empathy, because you're absolutely right. The patients feel the exact same as somebody with epilepsy, only so much worse because they've had so many people say, just stop doing this, or, why are you back? All these things that are just so awful. And even stuff that we as clinicians are not aware that we're saying, it's in the implicit speech. So if you say, well, you don't have real seizures, what is that implying? They must be fake. So this is the kind of stuff that I've gotten very interested in, how we communicate with patients. And when I give talks, I say the treatment starts the minute you meet the patient. Everyone talks about it's when you present the diagnosis, but I say, no, it's when the patient enters your office, how you listen, how you look at them, and how you really respect them. And I think if you know anything about trauma-informed care, I think in this patient population, you have to use it with everyone, empower the patient. Because what Dara said is very important, that patients who don't believe the diagnosis, or who are saying, oh no, here we go again, another person, they jump to the conclusions. That's part of this circuit that functional seizures has, like sort of been there, done that. I know what this is, predicting that this is going to be bad, and they stop listening, just like we do. I mean, this is all of our brains. And so you need to kind of make that first impression, like, I'm going to be a little different. I'm really want to help you. And that's what I say to them. I want to help you. I know you're suffering. This is real. It's common. Yeah, the names, we got it wrong a bunch of years ago. I even bring that up. And especially in the pediatric world, I learned from Kasi Kozlowski, who's a pediatric psychiatrist in Australia, that our words really either can promote health or lead you in the wrong direction. So calling these psychogenic, every kid knows what psycho means, right? And so you're leading off with a term that is not as understood or appreciated, or maybe it is understood, and why even clinicians got it wrong. So I know it's a long way of saying it, but I approach it very similar to Dara, but adults may be a little bit harder. It's not like they have that, hopefully, warm, loving parent. It's not always the case, I'm sure Dara knows, but somebody there that will help them, because I understand pediatric patients may do better than adults, although I'm told by some that they may just end up maybe not back in the neurologist's office, but they have other issues socially. So that's why that isolation that Dara spoke about is particularly harmful. Like homeschooling for these children is even worse. The other thing I would say about adults when I approach them is it's a two-way conversation. I'll pause and I'll say, so what do you think about what I've said? And then I'll wait. And some patients, will say, oh, that makes sense. Or they'll say, I don't know really what you're talking about, or that is not me, I'm sorry. But not too many will say, I'm out of here right now. They'll just not come back. And part of our issue has been we've, as neurologists, as a group, have not been following them. So in addition to what Dara said, it's not just, yes, a clear-cut diagnosis, being able to distinguish, maybe people have both types. We didn't get into that yet, like both epilepsy and functional seizures, which is a very challenging topic. But also in staying with them until they're ready to engage in treatment. Some people are just not ready. I've learned, because I'm from New York and I'm a neurologist and I move quickly, that in this group of patients, you got to slow down because they may not be ready until the last 2 minutes of the appointment as they're heading out, or a year from now, or 5 years from now. And if you say, you don't need to see me again, there's nothing I can do, I've made the diagnosis, that's where we've, I think, gone wrong. And we've been wrong. Sometimes people have both. And a recent experience with a patient, Dara, that was on our patient talk for our course recently in June, if anybody's interested, through the FND Society, there was a course that that myself and Dr. Yogaraja ran on people who have both. And I have a patient that speaks. I met her years ago for a surgery, for refractory epilepsy. Took years to get her to surgery. I wondered about some of her prolonged prodromes that seemed a bit off, but she was adamant that, she wasn't going to let me pursue anything other than what we knew, that she had epilepsy. And after her surgery, she developed some of the worst FND I've seen, multi-type. Her epileptic seizures went away. And so, we really have to drop this, psychiatrists see patients with things wrong with their mind, and epileptologists see epileptic seizures only, because that's where we get it wrong. I may not have answered everything you asked.
I couldn't agree more. FND is a brain disorder, and we are brain doctors. So we need to remain engaged with these patients, let them know that we remain available to them, follow up, give them our office numbers they can call with questions. I totally agree with what Barbara just said.
Yeah, and everybody's concerned, oh no, I don't know what to do. They're going to keep calling me. I've found when you set up a multidisciplinary team of people that you can reach out to, it really is in many ways sometimes easier than patients having epileptic seizure after epileptic seizure, where they're really you've tried every medicine and whatnot, or they don't qualify for surgery. So just like with any disorder, about 30% of patients don't get better, and so we have to keep that in mind with this disorder as well.
Awesome. Thank you so much. So I think we've done a really great job kind of going over diagnostic differences between adults and peds. And I think, Erica, would you like to take it to the next step with our outpatient differential, EEGs, warning signs, all of that?
Yeah, I think this was a great time to segue into the ideal scenario, which is a patient presents in the outpatient context for differential. Am I having epileptic seizures? I'm sure they don't have functional seizures on their differential at that point, but you might. And then later we'll talk about a less ideal scenario, I think, when patients present to the emergency room. To get us started, let's start with Dara for this one. Can you describe the process of outpatient diagnosis, including rule-in signs, flags for differentiating epileptic from non-epileptic seizures, and any key components from your history? Like if you could ask just a few questions, what are the core ones that you don't want to miss to make this differential?
Yeah, absolutely. And you're totally right. Nobody walks in my office, thinking I have functional seizures. It's usually, I think my kid is having epilepsy, or they're just having these really scary episodes and I'm terrified and I don't know what it is. And I need you to help me figure that out. So, the history is so important, just like every neurologic condition, epilepsy included. We have to live and die by our history, right? So taking a very careful, thoughtful semiology history of like what exactly happens before, during, after the event is really, really important. And what are the situations or locations where the events are likely to occur? So especially in my teenagers, I find Oftentimes, more of the events are happening at school. And I say, well, what about the weekends? Oh, they don't really happen as much on the weekends. Or, when I'm hanging out with my friends, it's more like they're happening at school every single day, Monday through Friday, and then not so much on the weekend. That should be kind of a soft flag, right? That maybe it could be a functional seizure. But, so the location or the venues of where the events are typically occurring is a really important feature. And then what do the actual, movements themselves look like if there's a convulsive component? I find many times families have already had the instinct to video record these episodes, or the school has recorded them. And so do we have any videos to review where I can actually see the movements? And what I'm looking for is, are the movements symmetric? So is both sides of the body moving at the same time? Are they synchronous, like moving in a rhythm that I could set a beat to? Or are they sort of erratic, movements, shoulder thrusting, pelvic thrusting type of, movements that wax and wane, fluctuating. The duration of events can be very telling as well. Certainly people with epilepsy can have an episode of status epilepticus, but it's not super common for somebody with epilepsy to have every single event be 20 minutes, 40 minutes, 3 hours. I've had patients tell me that they're in and out of functional seizures, in clusters for hours. That wouldn't be very typical of epilepsy. And then probably some of the most important questions that I ask are about warning symptoms. I would say most of the time, my patients can recognize when they're about to have an event. They have some sort of feeling, sometimes multiple feelings. I get a headache, I feel hot, I feel palpitations, I start to hyperventilate, I just feel something scary is about to happen. I can tell it's going to start. So yes, I have we flesh out what are the warning symptoms. And then my next question, which I find so valuable, is, have you ever been able to slow or stop one of your events when you felt the warning symptoms? Like just kind of hold it in until you could get to the bathroom to have it alone with, without your friends watching you or something. And many times they have, without even realizing it. They just like, oh, I tried to distract myself. I tried to, grip a fidget or a stress ball or something. I tried to do something to hold off the event. And many times they are slightly successful. So they might be able to like push it off for a little bit, but then eventually they wind up having one. And sometimes it's even bigger because they tried to hold it off. It's like a much more intense episode. But just that little glimmer of being able to have some control over it is so telling, because that would not happen with epilepsy. We would, some epileptic seizures, of course, can have auras and warning symptoms, but you wouldn't be able to sense your aura and then be able to like will a seizure away, think about something else, distract your mind, and like make that epileptic seizure just stop in its tracks or slow down. So I find that to be a very helpful question. And then, of course, the questions of, do you have memories of the event? Can you hear people talking to you during the episode is another very helpful one. I find many times they'll describe, yes, I could hear them, but it sounded like they were muffled or underwater. I couldn't respond. I tried to talk, but it came out garbled, or couldn't talk at all. That's also very consistent with functional seizures. So that's really, the most important piece is listening for those positive semiology signs. So the description of the events that, really only fit with functional seizures. If you can check all of those boxes I just described, that really only fits with functional seizure. And then using that to explain to the family, like, these things wouldn't happen with an epileptic seizure. So here's why this is functional and not epilepsy. Of course, there are other things that might cause somebody to, for example, pass out. We think about syncope, but somebody wouldn't have syncope and be out for 45 minutes. So like that's a distinguishing feature between that condition. Likewise, POTS, which could be a cause of passing out. So really it comes down to the description, listening for those positive signs in the semiology, and then reviewing videos if we have them. And then if we're still not certain, the gold standard is capturing an event on a video EEG. I don't find that that's necessary in every single case in pediatrics. We're very fortunate that we have a lot of eyes on the kiddo, right? They have their parents, their siblings, their friends, their school staff. As I already mentioned, many times somebody will think to record a video or maybe several videos. And so I already have, as Salim Bambatis would say, half of an EMU in their pocket. And I can see the events themselves. And so I don't get an LTM, a video EEG in every single case, because I don't find that it's always necessary. But if there's some question, or if we have a diagnosis of epilepsy as well, and we're trying to differentiate events, then the gold standard would be that video EEG recording, trying to capture an event on the EEG.
Can I add to that, Ayushe? So that was excellent, and most of it applies to adults. Although that there was that pediatric paper by Fredwall and others in 2021 that showed time to treatment in peds is really what makes a difference, and kind of advocates almost for like, don't wait for a year to get the video EEG. And it's really hard. They're transient episodes. It's a little different in other areas of FND where you can examine the patient having the weakness or having the tremor. For us, most of the time, they're not having the episode, they're talking about it. And the way it's described is not always clear because everyone's panicked at the time of an episode when you see a loved one having a prolonged neurologic event, which can be very disturbing and dramatic in the seizure realm. So the only thing I would add about the diagnostics is just to kind of mark what Dara said as importance. The convulsive episodes, very helpful for a video. You don't need the EMU because you have those elements that are, some of them are highly sensitive and specific based on an article by Avbrasek and Sisodia, like in 2010, showing like what are the most salient and specific items that you can trust. But you need that seizure to look at. That's the positive sign. That's what makes it challenging. The episode may be a minute or two in somebody, even if they have functional seizures, although it's more typical that they're longer. When it's not convulsive, the data shows that it's much harder, and you could miss the actual episode. You get the postictal state and be fooled because people can be crying and emotional and whatnot. And so the video EEG can be quite helpful if you can capture the key episodes. That's the other piece. A lot of times where we go wrong is we capture events, they're EEG negative, but they're not like classical functional seizures. There's just sensory tingling or some kind of breathlessness or whatever. So it could be another diagnosis. It really has to say, like, this looks like a highly specific, sensitive, positive sign of seizure. And if they have multiple types, sometimes that's the other reason we go wrong. Someone has both, you stop the seizure medicine, they have an epileptic seizure, and you're like, oh, we're done, not capturing the other types. I usually wait at least a night with them on meds and try to see what might be able to trigger them. And many patients do have it within the first day or two. Again, because this is not fake at all. These are kind of like akin to panic attacks without the panic. So I wanted to also highlight what Dara said about some of the symptoms. So symptoms of shortness of breath, palpitation, sweating, pallor, these physiological symptoms of panicky feelings when patients are not aware that this feels more physical than coming from, some anxiety, because either they're so used to it or they don't have words for it. That's often also a part of the syndrome. And that's partly why in the UK they're called dissociative seizures, because dissociation, which I also ask about in the adults, for children, it may not be, you have to use the right words. But I'll say, have you ever had an experience where you felt outside your body or you're not really there? And you'll get people to say, oh yeah, I have dissociation. Or I will ask now which I didn't used to, I'll ask about, have you ever had a panic attack? Have you ever had an episode of fainting? Because I'll learn that, they may have had childhood fainting that got diagnosed as vasovagal syncope, and, panic attack that went away with medicine or something. But all of that, again, it's not diagnostic, but it starts to be suggestive where you're starting to make sure you don't miss it in the differential. For me now, I include it almost in every neuro patient because it's so common. I just, put the order different. Like if I think it's very unlikely, I'll say, could also be, something that we call functional seizures. I explain it a little bit, but I'm putting that lower down. I think it's more likely to be vasovagal or whatever. And that's just a really good habit to get into because you'll see it in people with Parkinson, not the seizure type, but Parkinson's, MS, stroke. And the only other thing risk factor wise is if somebody has a history of ED visits where they had a TIA diagnosed and nothing was found and things like that, that goes as a little tick mark in the back of my head to ask about it. Because when I talk to emergency docs or intensivists, I'll say, if you don't think it was a stroke, tell them we did not find a stroke. We do not think you had a TIA. Otherwise, it just goes along with the history and everyone's like, oh, I better take this a lot more seriously and do a bazillion more tests.
That's a great segue into the second part of my question, and we're touching on ED visits, which is our next topic. But before we transition topics, could you briefly speak? And since you're on a streak, Barbara, for a population that's already sort of at risk for additional tests, additional interventions, or the iatrogenic harm, what's your threshold for referring for additional tests to rule out additional syndromes or contributing conditions? And you've touched on these: POTS, syncope, even vestibular migraines. Are you more cautious? Are you more liberal, or is it unchanged relative, same as you would for any other patient?
That's an excellent question, Erica. You hit right on the nose. We do have a lot of our patients in multiple subspecialty clinics, and the ones that Dara alluded to that may not believe you, they're going to go off and want more testing, and many patients do because they've been burned or something's been missed in a family member where some bad outcome happened, and they feel dismissed. That's why that initial conversation is important. I will lead with it really depends. If somebody comes to me with so many different, other diagnoses, and they've been around the block and had multiple tests, certainly I want to tamp down on the testing if I can and include some of the other experts that they're seeing. Because when you talk to the other people that are on their team, you'll find out that they didn't write it in the chart, but they've been suspecting that this is not, asthma, or this is not, an immune disorder of highly complex, and patients are getting ongoing, EpiPens for, whatever that are harmful. That's one end of the extreme. But for a new diagnosis, fairly straightforward. I try to limit testing. I think anyone that comes in with seizure pretty much is going to get a scan. They often have already had a scan before they'll see the epileptologist. But I think that, it may be different in pediatrics, but in adults, many of them have headaches. Many of them have other reasons. So one scan, I won't do multiple scans. Many patients want more and more scans with every, event that was longer or different or changed, which this can do. It can change in form. That's the other thing. It's not just fluctuating, it can morph. And so, and then EEG, if it really sounds like it, was seizure or a functional seizure, I think everyone deserves at least an EEG. And if there's very frequent events, either an ambulatory or try to capture one, as Dara said. But the way I try to control the amount of testing, I'll say, this really sounds very strongly like functional seizures. If I order a test, I'll say what I'm looking for. I'll say something like, I really don't think that we're going to find anything structural that is concerned, but I just want to make sure that there isn't any kind of a mass or a stroke. I don't think so, but let's get that out of the way quickly so that we can decrease that piece of it and then move forward. So I think the same thing for EEG, because we do see a lot of incidental findings on both of these tests, as you well know. And people will get their result before you have a chance to talk to them. Now, they release it quickly to patients, And, these are patients that are very worried about themselves. They suffer greatly. And they've, been to other physicians. They read, my kids read online too, what Google says and what the concern is. And then, they know it must be MS or it must be this or that. So I will say, unless there is something that really is diagnostic on the study, we are going to see some other things. I'm just going to let you know, please don't worry about some other minor things. We'll go over it, but those reports can be scary. So I usually set that stage because the predicting brain that we all have is going to jump to conclusions and really have a rotten week or weekend, depending on how long I get back to them. It's not like I won't order any tests, but as a very subspecialist, I may send them back to their primary care doctor and just tell them, please don't overly test, come back and talk to me if they have new neurologic symptoms. But people do have, ticks and fleas. And especially in this disorder, somewhere around 20% have both a neurologic disorder of, the ones that we're very familiar with, and this neuropsychiatric disorder. I mean, I'm not saying it's not a neurologic disorder, but it's both. So the overlap is very real. Usually the neurologic disorder hits first in patients that have both. But there are cases of people that have developed, for example, Alzheimer's disease or, movement disorders that was heralded by something that sounded functional without anything to show for it. And anxiety is just part, and depression is part of almost every neurologic disease that affects what I call zone 1, the brain. So I don't know if that's enough of an answer to your question, but that's how I proceed.
That's a very thoughtful approach, both considering the risk of additional testing, but also benefit. But importantly, if ordering testing, how you are phrasing it and discussing it and setting reasonable expectations is very thoughtful. And Dara, what are there differences or differences in threshold for additional testing in children, or more certain common comorbidities that you need to explore with more detail?
Yeah, so I mean, I totally agree with what Barbara said of like trying to, understand what are the patient's concerns, what is it that they're worried about, what are the things that I can reassure them based on my assessment, based on the history, based on the physical exam, without needing additional diagnostic testing. And I would argue we diagnose epilepsy without capturing an epileptic seizure on an EEG all the time. So we don't always have to have that gold standard, testing to be convinced by the history and the physical and all of that. And so if I'm able to, everybody in the room, the patient, the family, and me feel comfortable and confident in the diagnosis, then, maybe not pursuing additional testing. But if there are still lingering questions, there are specific concerns that the family has. I mean, as I mentioned earlier, really the first step in treatment is coming to the agreement that we all understand and are on the same page. And so, for example, I might have a family that comes to me that like they had another family member that had a brain tumor, and that is all they are thinking. My child has a brain tumor, and nothing you're going to say is going to move me past that concern until you get that MRI. Well, okay, then let's get the MRI. But as Barbara said, I expect it to be normal. I don't expect that we will find a brain tumor. We could potentially find, irrelevant incidental findings that are not going to, need to be pursued any further. But once we have reassured ourselves that there isn't a brain tumor, then, okay, let's try to move beyond doing more tests. We have to set the expectation. I think, unfortunately, historically, FND has been treated as a diagnosis of exclusion, in that people would, physicians would do a bunch of tests and then say the test is negative, so you have FND. And that sort of logic leads people to think, well, either that doctor isn't smart enough or they haven't done all the right tests, and I just need to keep doing more tests and seeing more doctors. And so if we flip that on its head and say, I am confident this is FND, and here's why, and let me explain it to you. And here's why we don't need to get a bajillion, more tests to understand this, then we can at least try to prevent that sort of line of thinking of like, we just need to keep doing more tests, more tests, more tests.
And the pre-test probability is really helpful before you order a test. Because I think to myself, will this test help me? What will I do differently about it? And is it, likely or not? When somebody who's 16 has had a lot of distress in their life asks, for a scan to be done, what's the likelihood that you're going to find something if their exam is negative and there's not a lot of history? So it's everything we do in medicine put together and try to contain the regress. It's actually, the last thing I'll say about this topic is that it's more common to miss FND and diagnose it as another disorder. And people end up, harmed by being on anti-seizure medication, sometimes for decades. And they'll come back to us. Certainly the average was 5 to 7 years before they make a diagnosis. That is improving. And I'll counter what Dara said before, saying nobody comes in and says, I think I have FND. I would say that used to be the case, but in the past year or two, I think the FND Society has made so much progress, and I'm sure the ILAE as well, that I've had some patients come in saying, hey, look, I've been reading about it. I think I have functional seizures. In the past, if they said that, it usually would mean that they had epilepsy. But now that we are making some headway. So that's very exciting news for me.
Awesome. Thank you.
Oh, sorry. That's so great to hear, Barbara. I think at this point, given you both have outlined very thoughtful approaches to outpatient differential and management that are very sensitive, very delicate, very nuanced, there's an opposite experience that I think our patients with functional seizures have unfortunately had exposure to, which is not that thoughtful or sensitive approach in ED settings. And Ayushe, if you want to lead through the line of questions about this particular scenario with functional seizures.
Absolutely. Thank you so much, Erica. Yes. So with all of the warning signs and rule and features that you both have mentioned, patients with functional seizures, both diagnosed and undiagnosed, often present to the emergency department with what looks like epilepsy to a staff member in the ED. And this is where things can go wrong very, very quickly. So I'd like to shift to the acute setting and discuss some of the emergency department or ED pitfalls. So just to get started, because one of the distinctions for me here is whether functional seizures are diagnosed or undiagnosed, I'd like to first dive in and discuss what's happening in real time when a patient with undiagnosed functional seizures comes in seizing in the ED. So what are staff typically seeing that drives their decision making? And how long into the epilepsy protocol should an ED physician start questioning the diagnosis? I mean, certainly, hopefully not after intubation, that doesn't stop the seizures. I guess from an adult perspective, maybe Barbara, you could speak to this.
Yeah, no, this is a very challenging area because the biggest consideration that an ED physician has is what can kill this patient, what time course am I dealing with? And it's usually ED clinicians and not neurologists in most EDs. So they're not as comfortable with FND. What they are most worried about is fear of missing something and having the patient go to harm. So it's just a little bit different thought. We have a little more time in the outpatient. And they're really weighing, it's like a scale, the risk of, over treating something that doesn't exist versus, missing something. And it often goes, we don't want to miss anything first in their mind. And I can see why that is, frankly. And, we'll talk about seizures in a moment, but let's just say for something that mimics stroke, there's good data to show that, giving TPA early is so important and you don't want to miss that timeline and it's actually safer to do that give it to somebody who doesn't need it, I hate to say, when you look at the data that I'm not going to quote, then to miss it. So that's where, I've learned from the ED physicians that that's true. I don't know if that's true in pediatrics where the risk of stroke is much lower. But for seizures, the ED, the first presentation of seizure or status is often to the ED before the diagnosis is known. And obviously there's a high risk of certain patients that are repeat attenders to the ED. And just for some statistics to show you how common this is, 9% of acute neurology admissions, at least in the adult world, pardon me, Dara, for FND, 13% of ED neuroconsults are FND, and 12% of strokes in the ED are FND. So it's an area of overlap that's high, and it's about 15% of functional seizures. Their first presentation is to the ED, and 25% of functional status, is seen in the ED. And we over medicate these people. I think I mentioned to you before that it's very high. So when patients first come in, it's important to know their history. Do they have a history of FND? Is this their second or third time coming in? That doesn't mean we ignore that this may be a different disorder. But again, if they've been in and they have a diagnosis of FND, it might make you slow down, giving them some, anesthetic agent, for example. Sometimes you don't have the benefit of a history, like someone just comes in. If they're seizing on arrival, people will assume status because we know that status epilepticus, if untreated at 30 minutes, can cause brain damage. And that 5 minutes, there's the assumption if they're seizing on arrival. And so that's the area where getting the ancillary history or talking to a neurologist or somebody who knows them would be very helpful and probably worth the time. But even when we talk to them, they sometimes still get treated, unfortunately, and still get, unfortunately, intubated. I've learned from my ED colleagues, it's sometimes because they need to move them out. The patient is behaviorally striking out or doing things in the ED, they need to control them. And so while it horrifies me, that may be another field that I'm not going to comment on right now. But the iatrogenic harm is real, including what Dara pointed out is many patients, not all, but many patients with functional seizures can hear what's going on around them. They just can't speak. And they can hear people saying things in the next room like, oh, she's back here again. Oh gosh, or just, why are they coming back here? Or anything that really is not great. Or they feel super worried, their family's worried, and they're put in a corner of the ED where they're not taken seriously. Worse, their clothes are ripped off if they think it's seizure, or they're tied down, or other things that if you have a history of trauma are exceedingly traumatizing. So that's the thing to keep in mind is it's very helpful to teach people what to do rather than what not to do. There's tons of stuff when you read on Reddit and online that say all the things that physicians do wrong. And so when I go to speak to people, I usually say, this is what would be helpful, and this is how we can help the patient. So if someone's in there, right away say, you're in the emergency department, you're safe. The sounds you hear are, it's your monitor, that kind of thing where you're trying to ground patients, some of the techniques we use. But I think that if it's the very first one, you're not going to get away, and especially if it's status, with testing them and maybe even treating them, Benzodiazepines, which are first line for status, unfortunately increase dissociation. But I think for the first seizure, we're not going to worry about that. It's for the recurrent ones and people that are saying the only thing that works is if I take my nasal spray or, benzo, or if I take an Ativan, because that might help stop whatever that panic, issue is as part of the seizure, that feeling, but it's not going to help in the long run. But short term, I don't worry about it so much. What I worry about is fairly quickly trying to get the diagnosis. And we get transfers from other hospitals that are already anesthetizing coma over, only to find out that many of them had functional status. So I don't know if that answers your question. I'm not an ED doc in terms of, time, this or that, but just to let you know, there was a trial in the ED at multiple sites called the ESET trial. It's published in the New England Journal a bunch of years ago. It was refractory status. I'm not going to remember here all of the initials, but it's a study that really tried to get pediatric and adult patients very quickly to treatment and look at different medications. And they had several different medications tried. If you look at the data, I was actually on the DSMB. I was head of the DSMB for that trial. And I asked the question, how do you know that some of them that you enrolled didn't have functional seizures? So that they looked at it, and it turned out 10.5% were enrolled, and actually later on, when they reviewed it, had functional status. And something like 48% had an adverse event, maybe, I can't remember, 30% were intubated in ICU, and then, 13% had some other harm, which I'm not remembering right now, but pretty high. And so it happens a lot. And I think especially because a lot of the clinicians in the ED don't have the kind of training that we're starting to roll out in education, as Dara mentioned, for the patient, for the families, for EDs, for clinicians, for APPs. There's more and more people that are working in these emergency settings. On the inpatient basis, when they're already in the hospital, we do also see patients having events, strokes, of course, and things like that. And having talked to just the Hospitalist Society this past month, they are getting more and more savvy, having protocols, making sure that you consider having some kind of flag that doesn't cause harm or bias in the ED that are frequent attenders. And you have to be careful. I know Wes Kerr at our course, said that can be helpful, but if you label somebody, there is some stigma that comes with it still. So you have to be very mindful, and especially for people who have both. That's the hardest area, is managing people with both. And we think we know, and think we know, and then come to learn that, what? The epileptic seizure was brief and it led to a functional event. So, it can happen, and it's a complex area. I'll just say that, and I'll let Dara see if there's other tips she has for the ED.
Thank you. Yeah, I actually had the same question for Dara, was how do you handle a scenario when a patient has both epilepsy and functional seizures and they present to the ED?
Yeah, so certainly, as Barbara alluded to, a very complex area. Just to make one little comment about something she said earlier about the ESET, the Established Status Epilepticus Treatment Trial. When we looked at the data, it was actually closer to 20% of teenagers that were enrolled in that trial actually had functional seizures. So pretty high number. And again, this was in emergency rooms in mostly academic settings that were, signed up to do a randomized treatment trial, not necessarily the typical management across the country. And so there is a lot of, mistaken identity happening in the emergency room. I totally agree also with what Barbara said, that like the first seizure presentation, it may be challenging to expect the emergency room in the setting of ongoing convulsions in that moment to be able to differentiate. I would love to be at the, in the world where emergency room physicians and folks that are EMTs as well, that are seeing these patients having seizures, could look at the movements and have some sort of understanding of like what is an epileptic seizure versus not. But I know that that's not possible in every situation. And so I agree that likely many of these patients may wind up getting treated. And then certainly if there's also a patient who has epilepsy presenting with an episode of seizure, it's very likely that they're going to initially get treated with seizure medication. So I think my best way of sort of thinking through this is, once we have established a diagnosis of functional seizures, whether it's just functional seizures or if we have both epilepsy and functional seizures, is really providing that outpatient or inpatient, but education with the patient and family on what this diagnosis is, and giving them a treatment plan, a response plan that ideally prevents them from going to the ER in the first place. Like, once we've established the diagnosis, especially if it's only functional seizures, we know that seizure medications are not going to be helpful. The emergency room is not going to be helpful, could even potentially lead to some inadvertent harm, as Barbara pointed out. And we sadly also see that on the pediatric side, patients getting lots and lots of benzos and even winding up intubated, being transferred to our ICU. So if we can avoid showing up in the ER to begin with, if we can have a good seizure response plan, recognize our warning symptoms and know what to do at home or in school or with friends, and not to call 911, then we don't have to deal with that. And so I think that's really an important piece of this as well. And when we have somebody that has both epilepsy and functional seizures, those response plans need to be specific. It's a part of my role as the epilepsy doc is to help tease apart. When this happens, this is my epileptic seizure. And when this happens, this is my functional seizure. And it's, there can be some similarities, but I also find many times there are clear differences with, for example, somebody with generalized seizures that does not have any sort of aura before their epileptic seizures. They just, boom, lose consciousness and have bilateral tonic-clonic convulsions, versus their functional seizure that does have warning symptoms that progresses over several minutes, and, partial awareness, partial memory, all of these details that we teased out earlier when we're taking the history. And then we can develop a response plan that is specific to each seizure type, to really help the patient and their family, and potentially ER doctors or school staff or whoever else might be involved in helping to take care of that patient, to know how to respond to each different type of event. I like the idea of some sort of warning or commentary in the chart. But I also recognize, as Barbara said, that could potentially be either stigmatizing or even just, we don't, having a history of functional seizures doesn't prevent somebody from coming in status epilepticus from an epileptic seizure, or having a stroke, or, some sort of brain bleed and presenting with symptomatic status epilepticus too. So we certainly don't want to bias people against intervening if it is an epileptic seizure. So it's a delicate, challenging question for sure. But as best as I can, if I can help the family have a response plan that keeps them out of the ER once we've established the diagnosis, that's where I really put most of my emphasis on.
One thing I'm going to add to that Dara said is, a lot of times, if you have this in public, a seizure in public, in the school or whatever, you're going to the ED. They're just medical legal issues make it hard for the establishment not to do that. And so, when patients say that, rather than blaming the ED, say, why are you back here? Sometimes it's unavoidable. They can sometimes refuse if they wake up, but once EMS is called, they're often like on that target. So having them have something in their wallet or sometime on them to say, this happens, please, try not to do that, can sometimes be helpful, or somebody with them if it's a high risk situation where they know, oh, if I go out there in public in this area, I'm likely to have one. So there's that. The other thing I didn't mention is, for the recurrent patients in the hospital or in the ED, connecting with their outpatient physician, who, if they don't have a neurologist, try to get that, but somebody who knows them, so that you can make that handoff to say, I saw this event in the emergency department. Sometimes the emergency department is where you learn that it's functional, because you've never seen the event. And, they don't video it for you, unfortunately, but you hear about it and you're like, oh, and you pause and you say, okay, that's very helpful. So using it like a partnership. And I want to hear if somebody, has had a seizure in the ED, whether it's epileptic or otherwise, and figure out what the next steps are. Because until you can educate even the patient to understand their own disorder, it's going to be a challenge, because a lot of patients, it's almost like a response that's so automatic and so quick. And there's almost, it's been reported, almost a relief in letting it just happen rather than trying to block it, which can be very, very hard. So there's I think John Stone wrote about it years ago, calling the unbearable lightness of seizing. So there's, and Mahinda Yogaraja has a paper too. We don't want to say that this is not on purpose, but there may be some relief coming that the patient says, I just have to let it happen so that then my brain has a reboot. So there's lots of ways that we can try to help them, giving them things that they can do before treatment starts that distract them, but not when it starts. Once it starts, it's really hard to stop it. So keeping them safe, making sure they're not going to injure themselves. So even though that doesn't cause brain damage, people still can get injured depending on where it happens. So that's the key thing is, do you have warning? Can you get to safety? That kind of stuff is key in the ED as well.
Giving the patient some agency to, if they do have warning symptoms, alert the people around them. I think I might have a functional seizure. I know what this is. Like, give me a minute to use my response plan or whatever the plan is. So that way the people around them aren't going to panic and call 911 instinctively. If you warn people. And then also with our school response plan, we explicitly say, do not call 911. We really discourage the school. Once we establish the diagnosis, of course, we really discourage them from calling 911.
That brings up a question I had. You both hit on so many of the questions that I had without my even asking them. I was curious about when patients present, how helpful previous documentation is. And of course, you've answered a lot of questions about what happens when patients have both or even other diagnoses. I'm curious, with someone with an established FS diagnosis, what do you tell their families or loved ones to do in terms of prolonged episodes? How do they know they should actually bring someone to the ED? And have you seen cases where repeated ED visits for the seizures are actually part of the pattern themselves?
Oh, wow. Excellent question. So again, it's so hard for a loved one to watch somebody having one of these. They're very dramatic, they look like convulsions, and to a layperson, how is it possible that this can happen? And it's not on purpose. And that's part of probably part two that you want to do on, how the nervous system does it, why it looks voluntary and yet it's not. But I think that there's, things that you offer the family to say for yourself, take your own pulse, if we feel pretty certain about that, and get them to safety. You can put your hand on them and say, I'm here with you. You're going to be okay. And what you're looking for, like, make sure they haven't injured themselves from a fall. For that, they go in. Something looks really different, a different type or whatever, where they're not breathing. I'm never going to fault them if they want to save their loved one. And sometimes it takes 2 or 3 visits to convince some people. And so I usually, that's their parents' agency. If it's a kid, they're going to be, all over a spouse. It's very scary to watch. And the loved ones know that this is not fake. So that's the other thing, that they know that this is real, and they know the character, that this is a person that has pushed through sometimes a lot of adversity, sometimes the strongest people you will meet. And that's why it doesn't ring true when we use the word psychogenic, which that implies somehow you can't deal with your stress, which is just not true. These are often patients that have dealt with unbelievable stuff over a lifetime. So I don't know if I've gotten to the point or gotten away from the point at this point, because we've been talking for a long time, but the bottom line is you can give some simple things to do at home, make sure the patient's safe, look for signs that people might miss. A lateral tongue bite might be hidden. You might have thought it was functional, but it might cause you pause. Stertorous snore type breathing going on after an event tells you, this sounds like it was an epileptic convulsion. And it might just be the aftermath where the person was acting really odd and it doesn't sound like an epileptic seizure. I've been burned like that. So I think just being unbiased, being open mind with every event, like listening. And then when the hairs on the back of your neck go up and like, oh, maybe I was wrong about that. It's okay to be wrong. And I'll tell patients that, like, look, I'm not always correct. I'm really listening to you. So I need, whatever data, especially many of these patients, you don't have all the data for maybe even several visits or even sometimes years. I hate to say it, if they're infrequent. The frequency can help you. And many patients with this disorder present like suddenly millions of seizures all of a sudden out of the blue. That's a red flag in my view think about functional, or do they have some really rare autoimmune thing, but those are often, pretty quickly easy to determine. But even the best neurologists get this wrong. And I think you have to be a really good general neurologist and a good listener.
Very true. Dara, would you like to add anything?
Yeah.
Cases where repeated ED visits for functional seizures become part of the pattern themselves.
Yeah, so to really underscore, what Barbara said, these are very scary episodes, and we have to acknowledge that. And when I'm talking with patients and families, I say that out loud. I know that these look really scary. I know that it's terrifying for you to watch your child have one of these, or it's scary for the school to watch, or what have you, to really, show them that we recognize that. And when we give a response plan, we give actually literally a sheet of paper that one side of the paper is for the child and the other side of the paper is for the family members. And we have a role for each. So the patient themselves has their role and the way that they are going to recognize warning symptoms, communicate, get themselves safe, and use a strategy. The family needs to also have a role and a part to play. Otherwise, panic sets in and it just doesn't go well. And so, we need to give the parents some agency in this as well, of knowing what to do. We also need to help them understand, we talk about that this is the nervous system sort of feeling overwhelmed. We didn't get into a whole lot of, explanatory models. That could be a whole nother hour conversation. But we talk about, that what's happening during these functional seizures may be that the nervous system is overwhelmed and overstimulated. And this is a way of it sort of self-correct that overstimulation. And so explaining that to the family and say, while your child is having this event, we know that they are safe. There's not an injury to their brain. As Barbara pointed out, we want to make sure that their body is safe. So I want to, make sure that they're physically in a place where they're not going to fall or hurt themselves, or have they already hurt themselves. Then obviously we need to make sure that they are safe. And then really convincing the family that the best thing they can do to help their child is not to add to the stimulation to their nervous system. So panicking, are you okay? Doing sternal rubs, tapping on the face. I've heard it all. When we don't know what's going on, those are our instincts, right? Or if somebody's thinking this could be epilepsy, those are things that we do during an epileptic seizure, right? Or somebody loses consciousness, we immediately start rubbing their sternum or checking their pupils, things like that. And I want to really help the family recognize that those things are adding stimulation to that already overwhelmed nervous system, and that could serve to prolong the episode. So genuinely, the best thing they can do to help their child is to back away a little bit. They don't have to be alone, but I'm here, you're safe, as Barbara said, I'm here, you're safe, you're having an episode. You let me know when it's over, and takes somewhat more of a hands-off approach. And we find that when parents can do that the events pass a lot more quickly. And then eventually the child really learns how to control them a little bit more themselves. They get some more agency themselves as they kind of learn their response plan. And then we don't have to panic, and we don't have to call 911. We don't have to go to the emergency room. So really making sure that the caregivers, the care partners, the parents, the family members, the friends, etc., have a role to play. And that role is not to add to the overstimulation of that person. That can be a very powerful way of giving some of that agency to the parents, without necessarily making things worse in that moment.
Awesome. You both touched on the typical cascade of harm when a patient with FS is treated for epilepsy in the ED. Barbara, can you share a case where a patient with FS experienced serious iatrogenic harm in the ED? And for both of you, what's one concrete change EDs can implement tomorrow to reduce harm to incoming FS patients?
Well, off the top of my head, I would say a lot of the harm in the ED is furthering the traumatic response. We have had patients intubated and having, sustained problems from that intubation, infection, pneumonia, prolonged hospitalization, fear of hospitals where they don't want to ever come back. And so when we need to hospitalize them, it binds us in a way that is extremely challenging. So these things last, obviously limbic negative things that happen to us are not forgotten. Unfortunately, we forget the happy stuff, quicker. So I think mismanaging them is the biggest one. I've seen a lot the other way too, where, somebody was diagnosed with FND and turned out to have a stroke and was found 5 days later, because there was a language difficulty and there was, a loss in the family, mother had died, that kind of stuff, where the assumption, that's a pitfall, is like assuming because there are stressors or psychological factors. Right now, who doesn't have stress? So I think many neurologic disorders are extremely stressful. So if your question was like, the harm, luckily I haven't seen a ton of it. I've read about it. There have been cases of, people getting treated and causing death because you've given them an anesthetic drug and they didn't need it and they stopped breathing. And I think, we don't know the rate of all of that, if some of that has happened in the outpatient domain. But some patients, because of just what Dara said, if we don't treat that pathway to like, right to the ED, I have many patients that believe the only thing that will stop this is if I get an IV lorazepam. And that's a harm that, of course it may help and it relieves that stress then, but that the longer term harm and sets up that response, the brain, is looking for like, I need something to like stop this immediately. And unfortunately, we don't have a quick fix for this disorder. And there are many places that are not comfortable with treating it. I have to say one thing to Dara is that in the pediatric world, it's even more horrifying, the delays. Like I get people now coming up to the adult world are 18, 19. They've been diagnosed with FND maybe years ago, never been treated, never been told what to do, that kind of thing. And that is starting to change. I know that's not your program, Dara, but we need a lot more of these programs. I don't know if I answered your whole question, Ayushe, but my brain is going.
Can I add
Please.
something?
Yeah.
First off, thank you, Barbara. And I hope that none of our patients are are winding up in Boston saying nobody ever helps them. So, you asked, Ayushe, what can ER doctors do tomorrow? I totally agree with what Barbara said in terms of, reducing medical harm. But at the very least, we can also approach every single patient with some curiosity and compassion, to use words that Barbara mentioned earlier as well, and stop saying things that are harmful, dismissive, stigmatizing. I hear many times from patients and families that the emergency room doctor told them their child was faking, or like, why is she here? Or she's just trying to get out of school. I've even had parents tell me, because the trauma story is so prevalent in the adult world, I have heard families tell me that the emergency room doctor told them something must have happened to your child, they're just not telling you. And how horrifying would that be to a parents of a teenager thinking, oh my gosh, something happened and they're just not, they're not sharing that with me. So at the very least, we can stop harming our patients with our words. We can, approach every patient with compassion, and whether we know the right diagnosis or not. Right? We wouldn't, we shouldn't say those words to somebody with epilepsy or any other diagnosis. So that's something we can do tomorrow or today or yesterday.
And we can also let the ED doc know they don't necessarily have to make the diagnosis, but if they suspect it, it would be helpful if they shared that with the patient, saying, look, I know you were here for a seizure or stroke or whatever, we think it's this other disorder. We're not sure. We'd like you to see a neurologist, like just to bring it up, because otherwise they come out saying, I was in the ED and they said I had, just mentioning it in the differential kind of sticks as I had that diagnosis sometimes.
That makes perfect sense. And I know things like functional seizures are covered widely in things like CMEs at AES, but I'm curious if you also think that one way to reduce harm might be more focus in the med school curriculum, because while I've in the period since I started my PhD to now being second year of my postdoc, the name has changed 3 times. The research representation in neuroimaging has grown like threefold. And the last 10 to 15 years is when the disease went from being like something discarded at the gray no man's land between psychiatry and neurology to actually being something that neurologists can discuss in plain conversation.
Yeah, very important points, extremely important, and things that the Functional Neurologic Disorder Society has thought of, including trying to get this into the curriculum. There was a recent article by Sarah Finkelstein in a group here at MGB on what should be in the curriculum, because basically it's been a rule out and toss, as at least in my training, not neurologic, which is very, very far from the truth and is really stuck in some people with older training. The newer trainees coming through, the younger doctors are getting it. That's the other very, very hopeful thing that I'm seeing. The patients are starting to have advocacy with, some of the things that they read and they start to recognize. And one thing is there's these support groups that really should be thought of for your question going back a few questions ago to Dara about what do you ask, how do they explain it to their peers? There are support groups through the FND Hope. I don't know how much they do for kids, but I'm certainly young adults have groups there. So I am, much more hopeful that we are, starting to train, that people are getting it right. But there's so much more work to do, including like how it's documented in the chart and whether we even get billed for it, depending on what we call it. And the name change has not helped us. It makes us look like we don't know what we're talking about. I did one on what's in a name, for the FND Society, and found out from the patient stakeholder group, they're like, we're not worried what you call it, but we just think you guys just don't know what you're talking about because everyone calls it something different. And that's why, we're confused. So we got to stop the confusion. I'm not a believer in you need subspecialty groups only to deal with it because it's so common, but it is helpful to connect and to make sure that, we light like a flag, just like they've done with the opiate crisis or with harming adults with Alzheimer's disease and all these training. Maybe it's time to get a training for clinicians on this topic because it rises the healthcare costs. I mean, if you don't make a diagnosis early, all the extra meds, all the visits, all of the, harm, and it makes the patient feel worse. So I think that Mark Hallett, who sadly recently passed, back in 2006, called it a crisis in neurology, that this was so ignored, and really helped bring it to the forefront along with the founders of the FND Society, Alan Carson and John Stone. So I think it's really come a long way. And unfortunately, in medicine, things stick around a long time. And if you look up psychogenic, you'll see that much more than you'll see the new term functional. Right. Functional comes out as functional MRI and functional neurosurgery and functional medicine, and it's very confusing. So we still have a lot of work to do to keep us employed for a while, I hope, before AI replaces us.
Thank you.
Well, this was an excellent discussion. I can't thank you both enough for your time. It was truly an honor to have such knowledgeable, thoughtful, sensitive individuals who are providing such good care to these patients and advancing the educational, I was going to say opportunities, but I don't think that's the right word. How about need? The educational demand for training the next generation of clinicians and educating patients. And unfortunately, we're kind of building the plane as we're landing in terms of educating patients, educating clinicians, and doing both top-down and bottom-up management of patients as they're being diagnosed and treated, and the people who are treating them and interacting with them. And you highlighted all of that very, very thoughtfully. I'd also like to thank Ayushe for co-hosting this with me. It's a wonderful experience to not have to be on for every single question, just get to sit back and watch all of this happen for a little bit and be like, oh, that's a great question. These are great answers. It adds a different level of enjoyment. So thank you for that. This has been wonderful, and I think our listeners will really appreciate it.